This is a hint from Howard, Extraordinary Solutions for Restorative Challenges. I'm Howard Strassler. We're going to talk about things that we encounter in our everyday practice, things that build upon what we already do, but we may not have seen before. What if this patient presented at your office? How would you manage this challenge? Let's look at several cases that I've seen in my practice and that I had to come up with some innovative solutions. First, I have this patient who comes in. In fact, this was a fourth-year dental student who over the years I had told them to set up an appointment at the orthodontic clinic and get braces. And he said, I want a straighter smile, I don't want braces. I'll be entering practice in a matter of months, and I don't want braces. How am I going to handle this? And we'll see how I solved this restorative aesthetic problem. Or for this patient, and if you notice, he's had root canal therapy, endodontic therapy on tooth number 9. Number 8 is missing. He's got an open bite. He has aesthetic problems. He's got some functional problems. And once again, he's someone who doesn't want braces because I'm thinking if we can align these teeth, if we can put them in a proper position, it would be an ideal circumstance for solving the solution of the missing number 8 with an implant. But once again, that isn't the solution he wants. He wants something more immediate. Or for this patient, they can't bite into food with their maxillary partial denture. They're having pain. There's secondary and tertiary immobility problems, as well as some compromised periodontal disease. How are we going to handle this? Certainly a traditional splint isn't going to work, as well as, for this patient, concerns about the financial aspects. So let's take a look at how I came up with some solutions for these extraordinary problems. So the restorative solutions we'll be looking at are actually building upon things that I already was doing in my practice that many of you are already doing in your practice. So we'll look at these restorative problem solvers. First, porcelain veneers have been around since, believe it or not, late 1983, early 1984. I've seen some of my patients who have had veneers in place since 1984 that are holding up quite well. And for this patient, basically looking for an aesthetic solution, we did some conventional porcelain veneer preparations and we placed some porcelain veneers for this patient to establish an aesthetic result. And for the next two cases, you're going to see how I use my abilities and my knowledge with porcelain veneers for very routine cases and use them to solve some more difficult challenges. So here's the patient we saw earlier. And you can see the root proximity that's in place, the overlap between number 8 and number 9. In fact, one could say, well, why not crowns? And we'd end up with two of the thinnest central incisor crowns that you've ever seen. But for this patient, through some modified tooth preparation, I can create restorations that will be highly aesthetic. That will have some aesthetic compromises, some restorative compromises, but will be long-lasting. So let's take a look at how I approach this. And if you look on the right-hand side, that I'm looking at this overlap, the misalignment of the mesial of number 9. I'm looking at the lingual position of number 8. I'm looking at both tooth number 7 and 10 are in position. So how am I going to manage this? And once again, can I establish a proportionate result between 8 and 9? And so for my tooth preparation, if we take it to look at the lower left-hand screen, you can see that the width of number 8 is very normal, but the width of number 9 is very much compromised because of that mesial interlap. In fact, if you look at the mesial of number 9, I've actually severed, I've amputated the entire mesial of tooth number 9. How am I going to gain the width to end up with an aesthetic proportion between 8 and 9. And I'm going to rob Peter to pay Paul, so to speak, because take a look at the mesial of number 10. And my preparation, I've barreled into the facial of number 10 to about 1/4 of that facial surface. So let's look to the right-hand side. Look at the preparations that I've done. So we're looking between number 7 and number 10, number 7 and number 8, and it looks like a very typical preparation, minimally invasive preparation. I've barreled into the interproximal between half the contact between 7 and 8. And in fact, I've done something similar between tooth number 8 and 9, but you can see from this incisal view, I've flattened the surface of the mesial of number 9, so it's almost in alignment with the facial surface of number 8. The width of number 8 needs to be similar to the width of number 9, and the way I compensate for that, and this is where I'm robbing Peter to pay Paul, is 1/4 of the facial surface of tooth number 10. I've barreled into it, I'm still in enamel, and that I'm going to be placing the distal of number 9, in fact, on the facial surface of number 10, and you'll see that in the completed restorations. I make my typical bite impression tray impressions. I've done a diagnostic wax up with the lab, and we send it off. And so the final veneers, you can see 8 and 9 are very proportionate, but that 10 also has that appearance. But look at, and looking at the lower left-hand side, look at the width of the contact between the distal of 9 and the mesial of 10. In fact, you can see from the incisal view in the right-hand lower side that I've overlapped number 9 onto number 10. When I run floss between these teeth, it'll be sideways. But I've established an aesthetic result, taking into effect the root proximity and all the challenges that exist. What about this patient with one too few teeth, number 8 being missing? Look at the facial orientation and inclination of number 9. It's been endodontically treated. And so to restore this tooth, I have to bring the axial inclination more in alignment with the other teeth, which means I'm going to need to retain a composite core and build a composite core onto that lingual surface. And I'm doing that using a metal post. And you might say, why not a fiber post? I'm using a metal post because I want the rigidity of the metal for retention. I'm building up a composite buildup and then preparing number 9 with the composite buildup to be more lingual. And this lingual inclination of number 9 takes into account that I'm going to turn number 7 into number 8. I'm doing the best I can to flatten number 6, but it's near impossible to get a canine to look like a lateral incisor. Anyone who might remember with patients with congenitally missing 7 and 10 lateral incisors, that when we try to take the canines and turn them into laterals, they look like very wide, rounded lateral incisors. And keep in mind, this entire case is very much compromised. And so I'll be placing veneers from 6, 7, 9, 10, and 11. And also look at the top image. Look at where the gingiva is. And you might say, well, how about if you do some periodontal surgery and lengthen number 7? And I don't want to put that periodontium at risk. In fact, the patient's smile line helps guide me. And so when I complete the veneers, you can see that number 7 and number 9 are pretty much proportionate. I've tried to flatten up number 6, but it's still going to be a wide tooth, but it looks similar to a lateral incisor. And then from my smile view, you can see that for this patient, they're not showing the gingival of number 9. And I've established an aesthetically compromised result, but one that's very acceptable to the patient based upon the limitations that they gave me. So this is an extraordinary solution for a very, very difficult case. And notice in the upper image that I also closed the mesial dark spaces on both canines through the use of the veneers onto the lingual surfaces. And then for the patient where we had pain upon biting, occlusal trauma, we're going to take and scale and root plane that patient, but we're going to take into account that we can use fiber reinforced composite splinting with fiber reinforced materials. Something that we have a great deal of success with. And here we're looking at a very typical case where I'm using rib-on TPH fiber, wetting it, and embedding it onto the lingual surface, placing composite onto the facial to cross-splint these teeth from a facial direction, and ending up with teeth that no longer have any pain upon function, have no mobility. And this is a very routine case, no spacing. Very routine case, there's alignment. But then we have the difficult cases, the cases where we have misalignment, where we have spacing. And once again, this patient's chief complaint is, can you do anything to help the pain and do something where I'm not removing any teeth? And so I'm looking at the spacing, and once again, we're going to scale and root plane to bring these teeth back to health. And if you take a look, let's count the teeth, looking from the lingual. 22, 23, 24, 25, 25 and a half, 26, 27. In fact, we've got an extra tooth in this place. We've got spacing. And so when I'm going to place my fiber splint, and typically I place composite on the facial first, for this case, I'm actually placing the fiber first. These teeth are misaligned, and they're more easily managed by placing lingual channels created with a 35 inverted cone burr, and they can go through the enamel into the dentin. But it allows me to place my fiber much easier, that it'll lay in these areas, and I'll be using a 2 millimeter wide piece of rib-on THM. So here you see the fiber being placed within the channel. You can see the spacing between the teeth. And now with this fiber light cured, I can go and now build up the other teeth with composites proportionately to end up with an aesthetic result, closing the spaces between the teeth. Having the dental dam on makes things a lot easier. I can use polyvinyl siloxane interproximally between the teeth to give me an anatomic blockout. So the teeth are now splinted. I've been placing the composite. I'll now finish and polish and shape these composites to get this level of result. I can finish them a little bit more, get some separation, but remember how these teeth were spaced originally. And that in fact we have 5 incisors with the 2 canines because of that supernumerary incisor. From a lingual view, on the upper left-hand side, after the teeth had been scaled and root planed, and then the patient came back a week later, and then the splint being placed on the lingual surface, where we've gotten our aesthetic result. But once again, an extraordinary solution for this problem, using what we routinely do, which is fiber splinting for periodontally compromised teeth. And then you might say, well, how long do you expect this to last? Would it be better to do a partial or maybe a fixed partial denture? Well, we take a look at some long-term cases. Here's a patient who came in after scaling and root planing, and you'd think, gosh, 24 and 25 might be extracted during scaling and root planing. And after scaling and root planing, we wait a week or two for health to occur. And then we're going to go in and we're going to place a fiber splint. So here we're looking at the fiber splint that's been placed. The patient is a smoker. And let's take a look at the evaluation. I'm going to show you this patient after they come in. They're still smoking, where I haven't done any touch-up. How often do we see long-term cases where we do a lot of polishing, a lot of finishing, make it look just beautiful, and we wonder how come ours doesn't look that way? And in fact, we do that. Here's the patient at 8-year postoperative recall. You can see that the calculus is still present on number 24 and 25, and yet those teeth are still in place. The patient's a smoker, and so we're picking up some staining on the composite resin. But take a look at the health of the gingiva. Take a look at the fact that these teeth are still in place after 8 years. We've improved the prognosis significantly. And we can extend what we do with fiber reinforced composites to the case where we're going to be losing a tooth or there's a missing anterior tooth. In this case, the abscess incisor is removed, and I'm going to use the actual tooth as my pontic. And so after extraction, and this is now an hour after the tooth has been extracted, probably the easiest extraction I've ever done. You could use fingers, there was no bone around it. We then cut the root to the length of the space that we measure. We place a channel, class 3 preparations on the adjacent teeth, and we put the natural tooth back in place. And because I needed to do it more freehand because of the tooth's original position, here we're looking at the fiber reinforced bridge, and this is a week after placement. You can see the soft tissue still healing. We've gotten a very aesthetic result for what the patient originally came in with. Patient's much more comfortable in mastication. Let's take a look at a lingual view of this splint. And you can see that I've established basically a periodontal splinting for secondary occlusal trauma. I've also established an aesthetic result for this patient. And once again, you ask, well, how long is this going to hold up for this patient? And here we're looking at the recall at 6 years. Once again, this is how the patient presented. You can see some calculus interproximally between the teeth, but that's holding up very well. So what we're doing here is we're looking at things that we typically do, and we're taking and using extraordinary solutions for restorative challenges, using things that we do every day. For 2 cases, we use porcelain veneers. For the other cases, we use fiber-reinforced splinting using the rib-on material. This is Dr. Howard Strassler with hints from Howard to show you some things that are possibilities using your problem-solving ability. Thank you for watching. Thank you for listening.